Hi, this is the EKG lecture recording for the cardiology module. We'll be focusing on coronary artery disease and the effects on the EKG tracing, as well as indications for getting an EKG with chest pain. So chest pain is an indication for a 12-lead EKG. A person who presents with chest pain, palpitations, dizziness, or syncope to a primary care, urgent care, or emergency department should get a 12-lead EKG. Ischemia and infarction can often be visualized on a 12-lead EKG in the process of diagnosing acute coronary syndrome. EKG can also show evidence of prior myocardial infarction with pathologic Q waves. Ideally, we'd like the EKG in less than 10 minutes. In the primary care setting, an EKG may also be used to screen for, monitor, or diagnose cardiac conditions. Acute coronary syndrome. When we are thinking of acute coronary artery disease, we are primarily thinking of atherosclerotic plaques in the coronary vessels. The coronary vessels are those vessels that supply the heart. Acute coronary syndrome describes the process by which the myocardium is acutely not receiving adequate perfusion. Acute coronary syndrome is further broken down into categories: STEMI, or an ST segment elevation myocardial infarction; NSTEMI, or a non-ST segment elevation myocardial infarction; and lastly, unstable angina. All three of these patients would likely present with chest pain. In a STEMI, we can see evidence of damage on the EKG. In an NSTEMI, the patient has symptoms, but we don't see evidence on the EKG. We do find evidence in the blood work, in the biomarkers that show damage to the myocardium, so troponin and other markers. In unstable angina, the patient has symptoms. There are no clear-cut indications of an ST segment elevation myocardial infarction, and the cardiac biomarkers are negative. Acute coronary syndrome is the acute presentation of the effects of coronary artery disease. There can be an absolute or relative problem with perfusion. In the case of an absolute perfusion problem, there is lack of flow through the coronary vessel in one or more arteries, and this lack of flow prevents oxygen-rich blood from getting to the tissue. If the myocardial tissue isn't perfused, it will become ischemic and necrotic. In the case of relative perfusion problems, that means there is some degree of disease in the coronary vessel, but the heart muscle is demanding more blood and blood flow. In this case, in a relative perfusion problem, the heart muscle cannot meet the demand. So if you were running or doing some sort of cardiovascular exercise, or even if you were sick and your heart was trying to increase its rate, the heart may not be able to supply itself with adequate oxygen-rich blood because the vessels are too clogged or stenosed with cholesterol plaques. When this happens, there is a characteristic change in the EKG. The characteristic change we're referring to is ST segment elevation or depression. Again, in the case of a STEMI, we have ST segment elevation. We define this as greater than 2 millimeters of elevation in the precordial leads, or greater than 1 millimeter of elevation in the limb leads, in at least 2 contiguous leads, which means 2 leads together, such as V1 and V2, or V3 and V4. In an NSTEMI or an unstable angina, the EKG may have T-wave inversions or depression, or even be normal. NSTEMI and unstable angina are differentiated only by biomarkers, so troponins, CK, CKMB, and myoglobin. So in acute coronary syndrome, there is excessive demand or inadequate supply of oxygen and nutrients to the heart muscle. This can be associated with disruption of atherosclerotic plaques, a thrombus formation around the plaque, or vasoconstriction. Atherosclerosis causes a narrowing or a stenosis of the coronary vessels, and it can be in one or more of these vessels. A crack in the plaque or a ruptured plaque can increase the stenosis, and a thrombus, as you can see here on the right, can also block perfusion through a coronary artery. If there is blockage due to any of these, the myocardium does not perfuse normally. Acute coronary syndrome can be classified in several ways. The first way is by the waveform on the EKG itself, or the waveform morphology. So this is the difference between an ST segment elevation myocardial infarction or a STEMI versus a non-ST segment elevation myocardial infarction or an NSTEMI. We can also see Q waves or transmural involvement versus non-Q wave. This is old terminology. Q waves refer to infarctions that are transmural, and non-Q wave MI would refer to a myocardial infarction where the damage was only subendocardial and did not result in a Q wave. This is old terminology and not frequently used. We can also classify a myocardial infarction based on age. Is this an acute STEMI, subacute, or an old infarction, such as seeing a Q wave on the EKG? Old infarcts can cause scarring, fibrosis, or associated aneurysm. We also classify MIs based on localization. For example, the wall of the heart that's affected, such as the inferior wall, or localized by the vessel involved. For example, the left anterior descending. Myocardial ischemia, injury, and infarction. Ischemia refers to lack of oxygen or inadequate tissue perfusion, can be reversible, and is related to decreased blood flow. This is part of the reason why the faster we get you to the cath lab for reperfusion, the better your chances are. Ischemia may present on the tracing as ST segment depression or T wave inversion. Ischemia may or may not result in an infarct or in Q waves. Myocardial injury, this is related to prolonged ischemia. There is a degree of reversible anoxia from decreased blood flow. This is represented by an ST segment elevation or an injury pattern. This may result in an infarct and may or may not develop a Q wave. Infarction. Infarction is the term for death of a tissue or necrosis. This is irreversible damage. This is typically represented by a Q wave. Infarction may be transmural or all the way through the myocardium. Not all infarcts will develop a Q wave. Just a reminder of the blood supply to the heart. Recall that the right and left coronary arteries supply the heart muscle itself. They arise from the ascending aorta, and this happens right as the aorta leaves the left ventricle. If there is any kind of stenosis, or if there are atherosclerotic plaques in these vessels, it will affect how well the cardiac muscle itself is perfused. I like this image because it shows you the extent of real estate that the coronary vessels are supplying. You can see here the left main coronary artery, which is labeled LCA on this diagram, gives off two branches, the left anterior descending and the circumflex. The circumflex heads off to the right side of the heart this way. Then there's the right coronary artery here, which is the right main, that gives rise to the posterior descending artery. You can imagine if there was a proximal occlusion in the left main coronary artery, it would involve a very large area of the myocardium. The extent and the location to where there is lack of perfusion or to where the vessel is occluded largely determines the extent of damage to the myocardium. As a review, recall the conduction system, the normal conduction system of the heart, starting at the sinoatrial node, followed down, depolarizing down to the AV node, down through the His bundle, the bundle branches, and the Purkinje fibers. If the areas of the heart with natural pacemakers, if those tissues are not perfused, it may jeopardize the conduction of the heart and cause arrhythmia. If areas of the heart are not perfused well, it will change the normal EKG tracing, and it will alter the tracing in predictable ways based on the location of the heart that is damaged. Also, as a reminder, the setup of the 12-lead EKG, we have the bipolar limb leads 1, 2, and 3 on the left. We have the augmented limb leads as well on the left. These are unipolar. We have all 6 of the precordial leads on the right side of the EKG tracing to make up our 12-lead EKG. Also, as a reminder of the intervals in the basic tracing, we have the P wave that signifies depolarization at the SA node. We have the QRS complex up to the T that signifies the depolarization and the repolarization of the ventricles. As we evaluate for myocardial infarction, we are going to pay close attention to Q waves, ST segment, and the J point. The ST segment. The ST segment corresponds to the plateau phase of the action potential, and normally this results in an isoelectric ST segment. So here's the plateau phase, and this is normally a fairly isoelectric ST segment. Acute ischemia is often confined to a very specific area or location, and this changes the tracing in this location. And so this can displace the ST segment up or down. When we talk about measuring the ST segment for elevation or depression, we first must find the J point. The J point is the junction of the QRS segment and the ST segment, or the point where the QRS segment ends and the ST segment begins. It's the first point of inflection on the upstroke of the S wave that is horizontal, and it leads to the T wave. These are multiple examples of what J points can look like. In this example, here's the RS segment, and the J point is right here where that ST segment, the first horizontal inflection is. Again, here's a normal tracing, the S wave to the horizontal inflection that leads to the T wave. In B here, here's the S wave, the J point where it leads to the horizontal inflection to the T wave. Again, the first horizontal inflection to the T wave. Here in ST depression, here's your S wave, the J point leading to the first horizontal inflection. In this last example, there's both a J wave and a J point. We will talk about J waves later. J waves are Osborn waves and they're related to hypothermia. In this case, the J point is still the first horizontal inflection on the way to the T wave. We analyze the J point for the absolute position, so whether it is elevated or depressed, as well as the shape. The J point can be notched or slurred. This is an example of slurring. And there's notching with the J wave present. You can also have notching and slurring together. So to measure the ST segment, after you found the J point and you found that first horizontal inflection, we measure the ST segment elevation or depression from the J point. We compare this to a reference point. The reference point is typically the PR segment. Some resources will say the TP segment, but the American Cardiology Association recommends use of the PR segment. So the J point here, which is that first horizontal inflection of the ST segment, is noted here in the normal. It's right at the baseline and it's isoelectric. If we move over to the center image, the J point is here. The baseline is this dotted line. And so the ST segment elevation is the difference between the baseline and the ST segment at the J point. In the last example, for ST depression, the baseline measured from this PR or PQ segment, and the J point, which is here, the ST depression is measured from the baseline down to the J point. This is another example. So the J point is here, which is the first horizontal inflection after the S wave to the ST, leading to the T wave. This is isoelectric, so this would be considered normal. In the center example, the J point is here, which is kind of that first horizontal or downward deflection as compared to the baseline. We can see that there's a significant amount of ST segment depression. In the final example, the baseline measured here from the PQ, you can see where the J point is the first horizontal inflection here to the T wave, so the ST segment. And you can see there's quite a bit of ST segment elevation in this last example. Again, the American College of Cardiology and the American Heart Association recommend use of the PR-PQ junction as the reference point for the baseline versus the TP segment. There is some controversy that exists there, and I've seen clinicians use both methods. And so what they're talking about is comparing the J point to the TP segment, so the T as it leads into the next waveform. So in other words, you would compare this J point to the TP section over here and see if it's either elevated or depressed. We're going to look specifically at ST segment depression and elevation because the depression and elevation can have very characteristic morphologies. The first morphology is an upsloping ST segment depression. Second is a downsloping ST segment depression, and the last appears more horizontal. ST segment depression may be a result of ischemic and non-ischemic etiologies. On the left, we see downsloping, horizontal, and De Winter sign morphology. These are much more consistent with ischemic patterns. On the right, we see an upsloping or very nonspecific ST segment or a concave ST segment, and these are much more consistent with non-ischemic etiologies. In ST segment elevation, there can also be both ischemic and non-ischemic patterns. Patterns suggestive of ischemia, such as STEMI patterns or ST segment elevation myocardial infarctions, have a characteristic appearance. Below, here are 6 common patterns seen with patients with STEMI. You'll hear classically the reference to tombstones. And so these are ST segments that appear to look like tombstones. This one here, this one, as well as this waveform down here. Non-ischemic patterns, such as pericarditis, tend to have a concave upward appearance to the ST segment. ST segment abnormalities can happen both with and without ischemia, and the differential diagnosis list is quite lengthy. For ST segment elevation, it could be a result of a myocardial infarction, pericarditis, pulmonary embolus, coronary spasm or Prince-Metal's angina, left main coronary artery disease, repolarization abnormalities, early repol, hypertrophic cardiomyopathy, Takotsubo's, or even a cardiac contusion. Not all of these are ischemic events, but they can all produce ST segment elevation. ST segment depression can be seen on the EKG tracing with myocardial ischemia, a true posterior myocardial infarction, which we'll talk about, digitalis, which is a medication, hypokalemia, left bundle branch blocks, or other abnormalities of repolarization. Not all ST segment depression is related to ischemia. Q waves. Q waves can occur normally in several leads. Normal Q waves are called physiologic Q waves. They are less than 0.04 seconds. So that means they are less than 1 box wide, and they are of low amplitude. Pathologic Q waves are greater than 0.04 seconds, so greater than 1 small box wide. You see them in leads V1, V2, and V3, and the depth of the Q wave is greater than 1/3 of the R wave height. So as you can see here, a normal Q wave is less than 1 big box, and the amplitude is not very high. A pathologic Q wave may be present, and it's usually wider, or at least 1 small box wide. Here's another example of a pathologic Q wave. This is greater than 1 box wide, and it's greater than 1/3 the amplitude of the R wave height. A QS complex shows that the entire complex is negatively deflected. Here's an example of that. So Q waves are the first downward deflection from the isoelectric line, and here's the S wave. There's no R wave present. So this is a QS complex. So here's another example of normal Q waves. They are less than one small box wide with low amplitude. And down here in the B example, you can see that this Q wave is wider and the amplitude is greater than 1/3 of the R wave. So next we're going to talk about how the EKG tracing changes with a STEMI. So STEMI criteria, so this is the ST segment elevation myocardial infarction. So the criteria are that you have ST segment elevation in 2 contiguous leads. That means 2 leads like V1, V2, V3, V4 that go together. And the ST segment elevation will be greater than 2 millimeters in the precordial leads and greater than 1 millimeter in the limb leads. The presence of reciprocal ST depression helps to confirm the diagnosis. Because ST segment elevation localizes, we can infer areas of damage based on the location on the EKG tracing. The first EKG change during a STEMI are called hyperacute T waves. These appear peaked and are related to localized hyperkalemia. They're broad-based and symmetrical with a high amplitude. So here is a wide-based, tall, or hyperacute T wave. These are rarely seen because they are transient and frequently occur prior to the hospital arrival. The next changes in the tracing with a STEMI are elevation of the ST segment. That happens within a few minutes. Within an hour, ST segment elevation will be present. The R wave amplitude will diminish, and the Q wave, or the pathologic Q wave, will start to begin. In the next phase, over the next 1 to 2 days, the T wave will invert and the Q wave, or the pathologic Q wave, will get deeper. In several days, the ST segment will normalize and the T wave will invert. Weeks to months later, if there is a Q wave that is formed, a pathologic Q wave can persist and the ST segment will, and the T wave will return to normal. Again, missing from this progression would be hyperacute T waves, which would fall right in here. But we often don't see those because those are at the time of presentation and may not be captured at the hospital. Localization of the infarction. So ST segment elevation, unlike depression, localizes to the EKG lead of the affected myocardium. ST segment depression should be noted in the reciprocal leads, or the opposite leads. For example, if you have an inferior wall myocardial infarction, it will involve leads 2, leads 3, and AVF. Reciprocal leads are those leads 90 degrees from the ST elevation. So for lead 2, 90 degrees is AVL. So we would expect to see ST depression in AVL. From lead AVF, 90 degrees is lead 1. So we'd also expect to see ST depression in lead 1. So for an inferior wall ST segment elevation MI, or STEMI, inferior wall, the reciprocal changes should be noted 90 degrees in AVL and lead 1. This is a great chart to memorize. This shows the wall of the heart that's affected, the leads where you would expect to see ST segment elevation, as well as the leads where you would expect to see reciprocal ST depression. It also correlates it to the suspected artery. So the area or the wall affected correlated to the suspected artery. If you do better with pictures and colors, this is just another variation of that. So it depicts the areas of the heart down below on the 12-lead EKG, and then it correlates them to the vessels up here at the top. And so we say the inferior leads are leads 2, 3, and AVF. Septal leads are V1 and V2. There's overlap with anterior leads as well throughout the precordial leads, V2, V3, V4. The lateral leads are V5 and V6. The high lateral leads are leads 1 and AVL. This image also correlates to my favorite picture, which is the heart that we studied with Axis, that shows the leads as well as plots out the lead axes. Looks like a globe. This is another way to think of it as well. So if you, again, remember the 12-lead tracing, inferior wall is represented 2, 3, and AVF with the right coronary artery. The septal anterior walls correlate to left anterior descending, and the lateral and high lateral leads correlate to ischemia or occlusion of the left circumflex. You can see if there is left main disease, it will take out both branches, the left anterior descending and the circumflex, and that is quite a bit of territory that can be affected. When you get your EKG tracing, you can be thinking of labeling it if that helps you. So with the high lateral leads in 1 and AVL, the inferior wall 2, 3, and AVF, septal leads in V1 and V2. There's overlap, of course, in V2, V3, V4, and then the lateral leads V6 and V5. This is a normal sinus rhythm, normal EKG. The rate is approximately 85. There are P waves, which we can see here in lead 2. There is 1 P wave for every QRS complex. The PR interval appears normal, so it appears less than 1 big box. The QRS complex is narrow. It appears to be regular, the rhythm. The axis is normal, so it is in lead 1 upgoing. If you look at AVF, it may appear more downgoing, but when you look at lead 2 to do the correction, it's positive, so it's going to spin it still into normal axis. If we want to check our work at the top, we can look here for the axis. Normal axis is -30 to 90, and so -8 falls into that range. So this is a normal sinus rhythm, rate of 85. So we're going to go over some specific patterns to look for in acute coronary syndrome. We're going to be looking at anterior STEMIs, inferior STEMIs, lateral STEMIs, posterior STEMIs, actually right-sided STEMIs, and left bundle branch blocks. First up is anterior STEMI. So this would be defined as greater than 2 millimeters of ST segment elevation in at least 2 contiguous precordial leads, anywhere from V2 to V4. We would see reciprocal ST depression in the inferior leads, mainly 3 and AVF. This represents left anterior descending artery disease. If it's extensive, you would consider main coronary artery disease. They also call this one the widowmaker. This is often associated with some of the areas of overlap, such as septal area in V1, and it can also be overlapped with lateral leads in V5 and V6. You'll note here ST segment elevation beginning in lead V2, and these do look much like the tombstone image over here, but V2, V3, V4, still ST segment elevation in V5 and can be argued in V6. You have definitely more than 2 millimeters here of ST segment elevation when you measure from the J point here down to the baseline or the PQ segment. That's definitely more than 2 millimeters, and it's definitely in more than 2 contiguous precordial leads. There are some exceptions to the 2 millimeter ST elevation rule. In men that are less than 40, greater than 2.5 millimeters is required to call it a true anterior STEMI. And in women, only 1.5 millimeters is required. So those are just some exceptions to the greater than 2 ST segment elevation, 2 millimeters of ST segment elevation in the 2 contiguous precordial leads. Now we're going to go through some examples. So if you look at this tracing, we note here that there is definitely greater than 2 millimeters of ST segment elevation. So we find the J point, we measure from the J point down to the baseline. That is definitely more than 2 millimeters. Same here in lead V3. I'm going to switch to the laser pointer. Definitely greater than 2 millimeters here. Continues over into V4, down here into V5, may trail off here into V6. But we would consider this an anterolateral STEMI. The rate is about 75. There are P waves. We can see P waves here. Here, it looks a little long with the PR interval here. So there may be a bit of a first degree block here. The rhythm looks regular. The axis, so lead 1 is upgoing, AVF is downgoing. So this is left axis. There's some low voltage over here in the lateral leads. And there's also some low voltage here in the limb leads on the left side here, the tracing. Here's another example of an anterior STEMI. So if you look at lead V2 here, you can see that if you measure from the J point down to the PQ line here, there are 2 or more millimeters of ST segment elevation. Continues into lead V3, V4, V5, and V6. So we would call this an anterolateral, true anterolateral STEMI. The rate of this tracing is about 80. There are P waves here. It appears to have 1-to-1 in front of every QRS complex. QRS complex seems pretty narrow. The axis, so upgoing in lead 1. This could be a little bit downgoing in AVF. There's also a little bit of maybe 1 millimeter of ST segment elevation here in lead 1 up here. Next, this is another example of an anterior STEMI. So the rate is about 80. There appears to be P waves here in front of every QRS. PR interval looks normal. QRS looks pretty narrow. The rate looks regular. The axis, so upgoing in 1, downgoing in AVF, so left axis. ST segment elevation starting in V2 here. So if you compare the J point to the PQ baseline here, more than 2 millimeters of ST segment elevation in leads V2, 3, 4, 5, and 6. So an anterolateral STEMI, and there may be even a little bit of elevation in leads 1 and AVL in high lateral leads. This means the damage is probably fairly extensive and may actually be left main disease. There's also reciprocal ST segment depression in leads 2, 3, and AVF. So this may be taking out the left anterior descending as well as the left circumflex, and is a fairly extensive area. Here's another anterior STEMI. The rate is a little less than 100. P waves, yes. They look a little funky, but there's one. PR interval looks like it's less than 1 big box here, or yeah, less than 1 big box here. The QRS appears narrow, regular rate. The axis, so upgoing in 1, upgoing in AVF. So this is a normal axis. And if I look up here, I can check myself, 83 degrees. Yes, that's still in the normal range. Normal, remember, is -30 to +90. The XT segments, if I look here, this is an anteroseptal. So if the lead V1, here's the PQ kind of line and the J point where the first kind of horizontal inflection is. We can see that that's more than 2 millimeters of ST segment elevation in V1, in V2, V3, V4. So I would call this an anteroseptal STEMI. And again, it's not isolated anterior STEMI, it's combined with other areas. Now we're going to talk about inferior ST segment elevation myocardial infarction. So you will see ST segment elevation in leads 2, 3, and AVF. There will be reciprocal changes often in lead 1 and AVL, as well as the anterior leads. The involved vessel is typically the right coronary artery. If there are atypical patterns, it could also include the circumflex and the LAD. Generally have a better prognosis than anterior wall STEMIs. You can have right ventricular infarction or right-sided MI in about 40% of cases of an inferior STEMI, so you should be looking for that. Hypotension in response to nitrates worsens the prognosis. So if you suspect that there's a right-sided MI associated with your inferior STEMI, you would not want to give nitrates. These patients can develop a significant bradycardia due to second or third degree heart blocks and can have this associated posterior STEMI or right-sided STEMI. So let's look at a few different tracings. So here's an inferior wall STEMI, and you can see the rate is really tough to see with these boxes, so we'll skip over the rate. But there are P waves here, likely normal PR interval. The QRS complex looks narrow for the most part, narrow here. Difficult to say, but in any event, there is obvious ST segment elevation in lead 2, lead 3, lead AVF. And again, you're measuring from the J point down to the PQ, the baseline here, and that definitely is more than 2 millimeters in those leads. The axis here appears normal, so upgoing in lead 1, upgoing in lead AVF. We can also see reciprocal ST segment depression here in lead 1 with this horizontal pattern, which is an ischemic pattern for ST segment depression. as well as AVL, which actually has a downsloping morphology to the ST segment depression there. Here's another example of an inferior wall STEMI. So again, the rate, in this case, we can march this out. The rate's about 75. There are P waves. It's 1-to-1. The PR interval looks fine, less than one big box. The QRSs, where I can see them, appear fairly narrow. The rhythm rather is regular. We see ST segment elevation obviously here in lead 2, 3, and AVF. And so what we're looking for again is that J point measuring down to the PQ isoelectric line, and we can see greater than 2 millimeters of elevation in two contiguous leads. So 2, 3, AVF. Then we look over here. AVL doesn't look right. There's some depression here. If we look at the precordial leads as well, we notice there's maybe the start of some ischemia here, but for sure in lead V2, we notice some very obvious ST segment depression, and it's the downward sloping kind, which makes us think of ischemia. We can see it here in V3, and again, a horizontal pattern in V4. This would make me concerned to look for a posterior myocardial infarction. And if I suspected a posterior wall myocardial infarction, I would need to get the posterior leads, V7, V8, and V9, to confirm. This is another example of an inferior STEMI. So the rate is about 100. When you march it out, I think I see P waves here in lead lead 1 and lead 2. Again, the rhythm looks regular. This is more downward deflected in lead 1, more upward in AVF. So this is a right axis deviation. We see ST segment elevation in lead 2, 3, and then AVF. We see it here in V6 as well. This is just another example of an inferior STEMI. I've got another one here. So again, we have rate. This is slower, so it's less than 40. I don't see any P waves at all here. So no P waves. So junctional. The QRS, where I can see it here, looks narrow. We see ST segment elevation quite obviously in leads 2, leads 3, and leads AVF, indicating the inferior wall STEMI. And again, you're measuring from the J point down to the PQ, and there's no P, but you're measuring to the baseline. We see reciprocal changes in lead 1. So here, that downward appearance of the ST depression, and again in AVL, that downward slope to the ST depression. Lateral wall STEMIs. So ST segment elevations in lead V5 and V6 and or in the high lateral leads of 1 and AVL represent the area of the lateral wall and the high lateral wall. We would see reciprocal ST segment depression in the inferior leads of 3 and AVF. The lateral wall of the left ventricle is supplied by branches of the left anterior descending artery and the left circumflex artery. Isolated lateral STEMIs are less common. Infarction of the lateral wall usually occurs as part of a larger territory infarction. For example, an anterolateral STEMI, which we just talked about. Lateral STEMI by itself is a standalone indication for emergent reperfusion. Typically, there's lateral extension of an anterior or inferior, and a posterior MI indicates a much larger territory of the myocardium that's at risk, and it has a much worse prognosis. ST elevation primarily localized to leads 1 and AVL is referred to a high lateral STEMI. Here's an example of a high lateral STEMI. In leads 1 and AVL, we see ST segment elevation. So here's the J point, here's the PQ segment, and we see more than 2 millimeters of elevation. We also see it here in AVL. And these aren't contiguous leads, but this would define a high lateral STEMI. We see isolated ST segment elevation there. We also can see hyperacute T waves in V4 and V5. Here's another example of a lateral STEMI that also involves the anterior wall. So this is an anterolateral, and again, lateral wall STEMIs do not typically occur in isolation. So an anterolateral STEMI is a large territory of infarction. We can see ST segment elevation present in the anterior leads V2 through V4, and again in the lateral leads V5 and V6. We can also see it in the high lateral leads of leads 1 and AVL. This is an extensive infarction involving the anterior, lateral, and high lateral leads. This is strongly suggestive of an acute proximal LAD occlusion, approximately 87% of the time. Here's one last look at a lateral wall STEMI. This is an infralateral STEMI. So we can see ST segment elevation in leads 2, leads 3, and AVF. We also see ST segment elevation in V5 and V6. The precordial may actually even extend out here till V4. ST depression is noted here in lead V1 and V2. And again, that's that downsloping angle to the ST segment depression. And even in V3, this may be a little bit horizontal. So this is an acute infralateral STEMI. When we look at V2 and we see this ST segment depression, we might consider a posterior infarction because there is a very large R wave. We will talk about this when we talk about posterior wall MIs. This constellation of EKG abnormalities is typically produced by occlusion of the proximal circumflex artery and potentially even the left main. So posterior STEMIs. Isolated posterior myocardial infarction is not very common. It is associated with inferior or lateral wall MIs. If you see ST segment depression in leads V1 through V4, think about a posterior wall MI. If the ST depression appears fairly horizontal, if you see tall, broad R waves, especially in lead V2, upright T waves, and especially this dominant R wave pattern in lead V2, strongly suspicious. You should be strongly suspicious of a posterior STEMI. You need to get a posterior EKG with leads V7, V8, V9. If you get a posterior EKG, you will see ST segment elevation in leads V7, V8, and V9 in a true posterior STEMI. The vessel that is involved is the posterior descending artery, which is a branch off of the right coronary artery. It should be treated like a STEMI. You can also do a little trick where you flip the EKG over and the V2 precordial lead will appear to look like ST segment elevation with a Q wave. So again, you have in lead V2, you have a prominent R wave with ST segment depression, often horizontal, but it can be downsloping. If you flip the EKG, it'll appear to be a deep Q wave with ST segment elevation. So again, this is just flipping or the mirror image of the EKG. You can turn the paper backwards as well. You would need to get a posterior EKG to look for ST segment elevation and confirm your suspicion. Here's another example of a posterior STEMI. So ST segment depression was noted in leads V1 and V2. If you can imagine flipping that, there's a very pronounced R wave in lead V1. The additional posterior leads were obtained, V7, V8, and V9. And you can see that there is, in fact, ST segment elevation in lead V7, V8, and V9. And this would be consistent with a posterior wall STEMI. There are also Q waves here in the posterior leads. Let's talk about right-sided myocardial infarctions. So in the presence of an inferior wall STEMI, you should look for the signs of a right-sided or a right ventricular infarction. And the reason is this changes some of your treatment. Patients with a right ventricular infarction or right-sided STEMI are very preload sensitive because the right ventricle does not contract properly. They can develop severe hypotension in response to nitrates or other agents that reduce preload. Hypotension in right ventricular infarction is treated with fluid and not nitrates. Nitrates are contraindicated. So in a patient presenting with an inferior STEMI, right ventricular infarction or right-sided STEMI is suggested by the presence of ST elevation in V1, ST elevation in lead 3 being greater than lead 2 because lead 3 is more rightward facing. Right ventricular infarction is confirmed by the presence of ST segment elevation in right-sided leads. So you would want to obtain a right-sided EKG. That means you're going to get leads placed on the right side of the trunk. So that'd be lead V3R through V6R. So just the opposite of the standard EKG tracing. You can also flip AVL, much like we did for lead V2 for a posterior STEMI. You can flip AVL to see if you see ST segment elevation to look for a right-sided STEMI, but you need to confirm with a right-sided EKG. Here's an example. So we see suggestive of an inferior wall STEMI here in leads 2, 3, and AVF. If we look at AVL, we see ST segment depression. We also see ST segment depression in V2. If you turn the EKG upside down, AVL looks like ST segment elevation. It's the mirror image of the inferior leads. The ST segment elevation is greater in lead 3 than in lead 2. So here again, the ST segment elevation is greater in lead 3 than lead 2. That's suspicious for a right-sided STEMI. This case, the cardiac cath showed 100% proximal right coronary occlusion. Let's talk just a moment about AVR, which is a lead that we haven't talked about at all. AVR is often the forgotten lead or the ignored lead. This is the lead that is oriented to look at the upper right side of the heart and can give information about the right ventricle and the basal part of the septum. The reciprocal information for leads AVL to lead to V5 and V6. ST segment elevation in AVR strongly predicts left anterior descending occlusion proximally in an end-STEMI. So for a patient who has no evidence of ST segment elevation in the precordial leads or the limb leads in the normal patterns, but they have ST segment elevation in AVR, this strongly predicts LAD occlusion, and that patient would have positive cardiac enzymes. It also can predict left main disease or left main coronary artery 3-vessel disease. Let's talk about imposters. So these are tracings on the EKG that may have ST segment elevation. However, they're not related to coronary artery disease or acute coronary syndrome. Those would be left bundle branch blocks, pericarditis or myocarditis, early repolarization, and Takotsubo's cardiomyopathy or broken heart syndrome. Left bundle branch blocks. A left bundle branch block occurs when normal electrical activity in the His-Purkinje system is interrupted. It obscures the ability to clearly see ischemic changes on the EKG. A new left bundle branch block in a patient with symptoms that are consistent with a myocardial infarction, so chest pain with exertion, or other symptoms consistent with acute coronary syndrome, should be treated like a STEMI. Left bundle branch blocks occur most often in individuals with heart disease. They can be asymptomatic and related to structural heart disease. There's some research that's raising the question of whether or not all left bundle branch blocks that are new should be treated like a STEMI. The concern is, are the risks of IV contrast and emergency coronary angiography worth it? The risks may be greater than the benefits of the patient presenting with chest pain. When taken to the cath lab with a new left bundle branch block, studies show that not all patients have blockage of the coronary arteries. As a reminder of what a left bundle branch characteristics are, we see a wide QRS in lead V1, and then we see the characteristic notched appearance in lead V6. We covered left bundle branch blocks in the pause video. Here's an EKG tracing with a left bundle branch block. If this were a new left bundle branch block in the setting of appropriate symptoms, we would consider ischemia, a cardiology consult, and the cath lab. So look in V1, you can see a wide QRS, basically a wide complex there. And if you look in V6, you see the notched R prime. If you turn the EKG 90 degrees to the right, and you look at V1 through V3, they're facing to the left, so you've got yourself a left bundle branch block. FYI, we'll cover this in the spring, Sgarbosa's criteria. So this is useful when you're trying to determine acute ST segment elevation in the presence of a left bundle branch block and in some cases paced rhythms. We're not going to go through this now. We'll come back to this in the spring, but this is a way to try to evaluate for ST segment elevation in the presence of a known left bundle branch block in a patient with symptoms. Pericarditis and myocarditis can also present with ST segment elevation. Pericarditis is a common cause of chest pain. Most common cause is viral. Myocarditis also has similar viral etiologies. The pain from these conditions is usually a pleuritic chest pain and is positional. Pericarditis is associated with inflammation of the pericardium, and myocarditis is associated with inflammation of the myocardium. Pericarditis, again, usually related to infections. Viral is the most common. It has classic positional pain, worse with lying down, and feels better when the patient leans forward. They may have a fever and leukocytosis or an elevated white blood cell count. they may develop pericardial effusion. The treatment there is to treat the underlying cause. If it's bacterial, you would treat with antibiotics, potentially drainage of the pericardial effusion if it is causing problems. NSAIDs or anti-inflammatories are often helpful. Myocarditis can be caused by viral infections as well, but also by autoimmune diseases and alcohol use. Patients may not have many symptoms with myocarditis, and it can be associated with pericarditis as well. The big thing with the presentation of pericarditis and myocarditis is usually on the EKG, they will have diffuse ST segment elevation that is concave upward with no reciprocal changes. So here's an example of what we mean when we say concave upward. The J point is here, and it's followed out to the T, and it appears concave upward instead of convex. So if you think about it, you can insert a smiley face here, concave upward, not ischemia, not a STEMI. Concave downward, this looks much more like that tombstone we talked about, and this is more indicative of ischemia and a STEMI. Here's an EKG in a patient who had pericarditis. Note the diffuse ST segment elevation in all of the leads and the concave upward appearance in the precordial leads. And also note that there are no reciprocal changes. So we have just diffuse ST segment elevation with this concave upward appearance here, but there's nowhere where there's ST segment depression as a reciprocal change. Early repolarization can also appear to have ST segment elevation. So again, the QRS complex out to the T represents the depolarization of the ventricle here and the ventricular repolarization here. And the repolarization occurs at the end of the S wave to the end of the T wave. If this process or repolarization is occurring earlier, it may displace the ST segment upward. There are a couple syndromes or occasions that are characterized by early repolarization. An early repolarization pattern consists of a distinct J wave or J point elevation, a notch or a slur at the end of the QRS complex, where it meets the ST segment. Traditionally, this is viewed as benign or benign early repolarization, but these individuals can be vulnerable to VTAC and ventricular fibrillation and sudden cardiac death. Early repolarization can be observed in acquired conditions as well, like hypothermia and ischemia. This happens mostly in males. Benign early repolarization. Usually, this is a benign EKG pattern with an incidence between 5 and 13% of people. It is very common, especially in young, healthy athletes and males. You will see ST segment elevation or J point elevation of 1 millimeter or more in 2 or more contiguous leads, usually in the inferior lateral leads or both. The ST morphology will be similar to pericarditis or concave upward, and you will see no reciprocal changes. Here's an example of benign early repolarization. Notice no reciprocal changes. Notice ST segment elevation in the inferior leads here, so 2, 3, and AVF, as well as in the anterolateral leads here, so in V3, V4, V5, and V6. Again, this is often in a young patient. Here, just note that the S wave here in the lateral leads doesn't go down below the baseline. We'll talk about that in a minute. So there are some abnormal J-point syndromes or early repolarization syndromes. Most noteworthy is Brugada syndrome. This is related to sudden cardiac death, sudden unexpected nocturnal death, or SUNS. It's familial, mostly males. The patterns are located in V1 through V2 and V3. There are 3 types. Type 1 Brugada shows a coved ST segment elevation that's greater than 2 millimeters with inverted T waves in V1 plus or minus V2. So this is the example of the coved ST segment elevation. You can see it represented here in V1 and V2. Type 2 Brugada has a more saddleback, kind of a sagging ST segment here with elevation, and type 3 has a saddleback shape as well. The difference here is that in type 2 Brugada, there's greater than 2 or 2 millimeters of ST segment elevation here at the J point. At the end of the ST segment, there's 1 or more millimeters of ST segment elevation. If you look at the V2, there will be greater than 2 millimeters at the J point. And then when you get to the terminus of the T wave, it will be down again at the isoelectric point. But they are very close in morphology. Takotsubo's cardiomyopathy or broken heart syndrome. This is known as apical ballooning. Takotsubo cardiomyopathy or broken heart syndrome, and this is triggered by emotional or medical problems. So for example, loss of a loved one or severe pain or a severe medical illness. They also refer to this as stress-induced cardiac or cardiomyopathy. And this is known as a reversible cardiac syndrome, and it's characterized by acute onset of chest pain that is associated with classic wall motion abnormalities that involve the apical region of the myocardium. And I'll show you some pictures in a few slides. This is more common than previously thought and more common in elderly women. Patients usually have EKG changes, including T-wave inversions, ST depressions, or even elevation. And that's coupled with their onset of chest pain that seems like a classic acute coronary syndrome. They will also have elevated cardiac enzymes. However, they will have a clean coronary cath. The diagnosis is confirmed during the workup with observation of apical wall motion abnormalities. Because stress-induced cardiomyopathy mimics acute coronary syndrome with its presentation as far as chest pain and with cardiac enzyme elevations and EKG changes, the diagnosis of this syndrome is based on exclusion of coronary disease by coronary angiogram. So they need to go to the cath lab and find clean coronary arteries. Here's several examples of EKG changes associated with Takotsubo's cardiomyopathy or broken heart syndrome, or stress-induced cardiomyopathy. So you'll see ST segment elevations here in the precordial leads. You can see, again, ST segments here in precordial leads. Over here you can see deep inverted T waves consistent with ischemia. here are some examples. And if you remember, during contraction or systole, the bulging ventricle resembles this pot used by Japanese fishermen to trap octopuses or octopi. I think both are acceptable plural forms of octopus. But you can see here is diastole, the filling of the ventricle, and then systole, when the ventricle is supposed to be contracting and ejecting the dye. It's not, the apical wall is not contracting the way the base is. And so for comparison over here, so here is diastole, so this is the filling of the ventricle, and then over here in systole, the left ventricle is contracting and pushing the dye out of the left ventricle. So this is normal wall motion over here, and in this case, the apical ballooning, where the apices or the apex of the ventricle is not contracting normally. And so here's just an example of what this Japanese octopus pot is, this tako tsubo. And so again, here's the normal shape of the left ventricle as it contracts after it squeezes. And then here it's the enlarged apex of the left ventricle that swells to look like this octopus pot. So even though we've discussed conditions that mimic a STEMI or that have ST segment elevation and do not necessarily indicate ischemia, if you're in doubt, you should call the cardiologist or activate the cath lab. Because time is muscle, it's better to have a clean cath in this instance than to wait for further damage to the heart. Again, I would remind you this chart is a really good depiction of the walls that are affected with the different patterns of STEMI, the areas for reciprocal depression or reciprocal changes, as well as the suspected involved arteries. This is really helpful. Okay, if you have any questions, please email me, make an appointment to see me. There are multiple practice 12-lead EKGs that follow this slide. As you go through them, I have the EKG, and then if you advance it and you're playing it on slideshow mode, the impression will be in a blue box on the side. So if you want to try to practice, you can put the PowerPoint in a slideshow format, read the EKG, and then if you advance the slide or hit the forward arrow, the blue wave will pop up and give you the read. And so I don't remember how many I put in here, but there are quite a few practice 12-lead EKGs, and not all of them show STEMIs, but many do. And so, again, not all show STEMIs, but it can give you some practice with reading for both arrhythmias as well as heart blocks and STEMIs.